In today's video, we'll discuss two common clinical situations involving fluid balance and wound healing. The first case focuses on the mechanism behind swelling in a patient with heart problems, and the second explores why some wounds are left partially open during recovery. Together, these cases highlight important principles in managing complications after illness or surgeries. A 60-year-old man with a history of prior myocardial infarction and a long-standing congestive heart failure presents with worsening shortness of breath and swelling in his lower limbs over the past several days. He also reports fatigue and mild abdominal fullness. On examination, there are elevated jugular venous pulsations, bibasilar crackles in the lungs, and a tender enlarged liver. When pressure is applied to the skin over his left ankle, a noticeable indentation remains for several seconds. What is the primary mechanism responsible for this patient's edema? Now, we are dealing with a patient who has long-standing congestive heart failure and is now showing signs of worsening systemic congestion, such as shortness of breath, leg swelling, elevated jugular venous pressure, bibasilar crackles, hepatomegaly, and pitting edema. The question isn't just about recognizing the clinical picture, it's about linking the physical findings to the underlying hemodynamic mechanism of his edema. In other words, why is that excess fluid leaving the capillaries and accumulating in the interstitial space? The options given here are A, increased capillary hydrostatic pressure, B, increased interstitial fluid pressure, C, increased plasma oncotic pressure, D, decreased interstitial hydrostatic pressure, E, decreased capillary oncotic pressure. Now the correct option here is A, increased capillary hydrostatic pressure, and that is because heart failure causes poor forward flow because the weakened myocardium cannot pump blood effectively after a history of myocardial infarction or other cardiac damage. And then this causes the blood backs up into the venous system because the ineffective pumping increases pressure in the atria and large veins. Now, the venous congestion raises capillary pressures, and that is because the elevated venous pressure is transmitted backwards into the capillaries. The hydrostatic pressure inside capillaries increases. This creates a stronger force pushing fluid out of the capillaries into the surrounding tissues. And then there is more filtration into the interstitial space, and the excess fluid accumulates outside blood vessels, especially in gravity-dependent areas such as legs and ankle. And you will have clinical signs of pitting edema. Let's have a look at why the other options are incorrect. Option B, increased interstitial fluid pressure, is incorrect because higher pressure in the interstitial space pushes fluid back into capillaries, which actually limits edema formation. And option C, increased plasma oncotic pressure, is incorrect because this would draw fluid into the capillaries, and no such increase in plasma protein concentration occurs in heart failure. And option D, decreased interstitial hydrostatic pressure, is incorrect because this would favor movement of fluid into the interstitium, but there is no physiological reason for this change to happen in congestive heart failure. And option E, decreased capillary oncotic pressure, is incorrect because this is seen in hypoalbuminemia, and which usually happens in liver disease and nephrotic syndrome. But patients with congestive heart failure They generally have normal plasma protein levels. A 58-year-old man undergoes surgical repair of a perforated appendix. On postoperative day 8, he develops fever, abdominal discomfort, and purulent drainage from the incision site. Examination shows partial separation of the wound edges with erythema and foul-smelling discharge. He is taken to the operating room for wound irrigation and debridement. Intraoperatively, healthy tissue is visible, but signs of infection remain at the wound margins. Instead of closing the incision completely, the surgeon decides to leave part of the wound open. What is the most likely reason for leaving the wound partially open? Now, this question is about surgical wound closure strategies such as primary intention, secondary intention, and tertiary intention, which is also known as the delayed primary closure. Now, in primary intention, wound edges are brought together immediately and it's used for clean wounds, and healing is quick with minimal scarring. In secondary intention, wound is left open to heal from the base upward via granulation tissue, which is common when infection or significant tissue loss is present. Now, in tertiary intention, which is also the delayed primary closure, wound is initially left open for cleaning and observation and then closed later once contamination risk is reduced. So in here, the students should focus on when each method is appropriate and how infection changes the closure plan. The options given here are A, to allow for drainage of intra-abdominal fluid, B, to allow easy re-entry, C, to allow eradication of bacteria by contact with air, D, to allow healing by secondary intention, E, to reduce scar size. The correct option here would be D, to allow healing by secondary intention. Now, in infected wounds, closing the incision would trap bacteria inside, worsening infection. Leaving it partially open allows granulation tissue to fill the wound from the base upward, promoting drainage and preventing bacterial entrapment. Let's have a look at why the other options are incorrect. Option A, to allow drainage of intra-abdominal fluid, is incorrect because if fluid collection were suspected, a drain would be placed intraoperatively. There was no evidence of intra-abdominal abscess or fluid requiring drainage. And option B, to allow easy surgical re-entry, is incorrect because this is sometimes done in unstable trauma patients. But in here, the infection is localized and the patient's condition is stable, and so re-entry is not anticipated. And option C, to allow eradication of bacteria by contact with air, is incorrect because wound infections require debridement and antibiotic therapy. Exposure to air alone does not eliminate bacteria. And option E, to reduce scar size, is incorrect because secondary intention generally results in a larger scar because of greater tissue loss and prolonged healing.